Thank you so much. So this case actually is along the same line of complications, mainly related to calcified vessels, poorly prepared. This is a 59-year-old male patient with a past medical history of hypertension, dyslipidemia, type 2 diabetes mellitus. He actually presented to another hospital in our community with anterior STEMI, and this is the angiogram they did. So they found that the LAD is occluded right from the ostium. The circ has moderate disease. The RCA has disease at the bifurcation into the PDA. But I think the first thing that catches the eye is that you can actually see the whole LAD without even any contrast going down the LAD, suggesting that it is a calcified vessel. I don't know if it's showing well there, but on the actual screen, when you see the detailed angiogram, you can appreciate how much calcium is there. So what they ended up doing is that they put a wire down the LAD. The first time it went down to a diagonal, they ballooned and re-established flow. And they tried to balloon more in the middle part. And as you can see there, that vessel would not would not dilate. In that spot, the balloon has a big waist, and they could not really open the area very well. And remember, this vessel, the LAD, was occluded right back from the ostium. So it is not like this is not the kind of the culprit, but it's part of the lesion that need to be treated. So subsequent pictures showed that they were struggling. I was literally going through their report, and they were struggling to deliver things. And essentially, they tried to balloon more at the proximal part of the LAD. Still, balloons would not open. And then they started ballooning more, especially at that with a bigger balloon at the area where it didn't open at all, beyond the first septal, and there's a big waist on the balloon. And next thing I saw on their angiogram is they delivered a stent into that area, but reading through their note, it got stuck and couldn't really be moved. And you can actually tell from their angiogram, because if you look at the LAD wire, every time it is like being moved, like either in or out, or sometimes into a branch. So it seems there was so much forward and backward motion, and definitely the stent did not open. So it seems they got stuck, and they decided at that point in time to just deploy rather than actually do anything else. And I think this is a situation where actually should have been prevented to start with, and the lesion should have prepared rather than to get like that patient into this situation. So subsequent angiogram, as you can see on the left side of the screen, like multiple complications already happening in front of our eyes. The culprit at the ostium of the LAD is dissected with the hazy appearance. The stent they put in the proximal to mid part is grossly underexpanded, with also dissection distal to it. And also you can start seeing some flow into a perforation, but you can appreciate it here on the right side. But it looks like it is like a septal perforation. So multiple complications happening because of not preparing the artery well and forcing the stent in, forcing their way in. So then they decided, and they added another stent distal to the one they just placed, which was not expanded to start with. And they also then stented the proximal part, as you can see here on the left side of the screen. They were coming in and out, but I definitely can tell if you look at the right side of the screen that they never actually stented the ostium of the LAD, where part of the big issue was happening with the patient. So if you can look at the left side of the screen, just at the ostium of the LAD, just beyond the circ, there is actually still severe narrowing there. So they never actually covered the ostium of the LAD. So, and you can see also the dye hanging into the septum. So multiple complications in one case, all goes back to the point of how important it is to actually prepare a vessel. So this was their final angiogram, and they admitted the patient to CCU. And essentially 12 hours later, as you would expect, the patient's having chest pain. So they do an ECG, there is new worse ST elevation. So they took him back to the cath lab, and they found the LAD to be occluded within the ostium, within that area that never really expanded well. So what they did is, again, more ballooning. And essentially, I even read through their notes some thrombectomy, which I really don't see why would it be helpful in this situation. But essentially, this was the final result on their side, the right side of the screen. And then they called and transferred the patient for any possible help from a complex PCI point of view. So the patient came to us, I think, the following day. Ejection fraction, when we did the echo, was 35%, akinetic apex, hypokinetic rest of the LAD territory. We had our MDT discussion, and we felt that the apex is probably all done deal. And because it's a grossly under expanded stent, we felt that maybe we can just optimize it to try to avoid a third MI in his case, or to save whatever can be saved in the LAD territory. But I truly think that much of the damage already happened. So we took him to the cath lab, and this was the first picture of the left system. So you can see that the LAD is occluded distally, but as I mentioned, akinetic apex on echo and QAs, and we felt that area we don't need to go after. So we parked our wire in a septal branch close to it. And then here, because you have a fresh stent and a fresh MI, so our options were really limited. So we cannot use rota, orbital. I think risk will be higher than benefit in this situation. So we decided to use shockwave. We use laser routinely. I think if shockwave didn't work here, laser was going to be a good option to use. So we used shockwave 2.5 times 12, but the shockwave balloon, actually, as you know, it is a bulky balloon, and in this case is like an area that is never expanded. So we only could get it like through the initial like 2/3 of that stent that never expanded initially. So we decided to start delivering shockwave pulses there, and then slowly build our way with non-compliant balloons before and after and into the lesion. And then I managed with the shockwave to go into the tightest part of that stent and managed to deliver shockwaves in that area. We did IVAS of the LAD just to confirm that the LAD ostium was not covered, because we wanted to cover that area, perhaps if it was not covered to start with. And as you can see on the IVAS, the ostium of the LAD was not covered with any stent, and there is significant plaque in that area with significant narrowing. So we decided to stent the ostium of the LAD, which we did. We do this routinely with ostial vessels, just like in an easy way, just to confirm that we covered much of the ostium, but we always compare with imaging after. So here are subsequent pictures, and essentially then with more shockwave at the stent where they had gross under expansion and more non-compliant balloons, we were able to expand it, and we decided this is, and based on imaging, we felt that this is a good enough result in someone who just had 2 MIs in a row and ejection fraction of 35%. So I think a few slides to use to illustrate the importance of preparing the vessel. As my colleagues alluded to, if you don't prepare the vessel, you end up in a bad situation. In one case, they were able to crush the stent. In another case, they managed to retrieve, but in such cases, they got stuck within the calcium. And if they pulled back, they would have probably unsheathed the stent, and the stent was going to be left within that calcium hunk, and the balloon will just come back by itself. So definitely, I think it is very important to know your enemy, and essentially when you see calcified vessel, then prepare to deal with it and prepare it as needed. But even if you don't see it, as Dr. Hamid mentioned, if you feel resistance and so on, then ask yourself the question, why is this happening? Do you need imaging or not? And then like be more aggressive with preparing the vessel rather than trying to shove a stent in. Regarding this, like the steps to prevent a stent loss, as you can see through this list, one important one is point number 2 is the meticulous vessel preparation and imaging, as well as all the other steps here. Avoid direct stenting in general, because sometimes you regret you managed to deliver it there, but then you see gross under expansion. Avoid like very forceful pushing, and be careful also when you use the guide liner not to to unsheath the proximal part of the stent as you pull back. So several steps to do it in a very safe manner. There is this OCT algorithm, OCT-based algorithm to help you understand the calcified lesions and help you choose which modality to use to treat such calcified lesions. I modified it the way we use in our lab in Cleveland Clinic. So essentially, it's very simple. For a calcified lesion on angiography, the first question is it crossable with OCT or IVAS or not? If it is not crossable, then most likely you need rotational or orbital atherectomy to try to actually cross that lesion and then do the imaging afterward. If it is crossable, then really doing the OCT image or even IVUS image will give you a good idea of what is the nature of that calcification, how circumferential it is there a nodular calcium and so on. And then based on that, and as you can see on the algorithm, you end up deciding, is the best solution a rotational atherectomy? Is it a shock wave? Or is it like a cutting balloon and so on? And then re-image and then stent. So I think imaging is also crucial in dealing with such calcified vessels to prevent a bad situation from getting worse. Thank you.